From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Health Tech, the show where we talk about healthcare and the technology driving it with the most interesting leaders in the industry.
Good morning, everyone. I'm Jeff Englander. I'm the founder and principal of Healthcare Strategy Bullpen. Welcome to Diagnosing Health Tech. First, quick note, Diagnosing Health Tech is now available as a podcast. Please search for it on your favorite podcast app and subscribe. And with that, I will move on to welcome our two guests. Very excited to have Susan Winckler and Carla Rodriguez-Watson here, both from the Reagan-Udall Foundation. Susan is the CEO of the Reagan-Udall Foundation, and I'll let Carla and Susan explain what that is and what they do. Susan is a pharmacist and an attorney by training. Susan is a wonderful colleague and friend, absolutely a person you want to know if you need to know someone in DC. Susan is the former president of Levitt Partners Solution, which was a national healthcare strategy firm founded by Mike Levitt, the former secretary of HHS. Susan is also the former chief of staff of the U.S. Food and Drug Administration from 2007 to 2009, in addition to a host of other accolades. So Susan, welcome.
Thanks so much. Glad to be here.
And in addition, from Reagan-Udall, we have Carla Rodriguez-Watson. Carla is the director of research at the Reagan-Udall Foundation. Carla has a PhD in epidemiology from the University of Washington School of Public Health, and her master's of public health from the Columbia School, the Mailman School of Columbia, which is just down the road from those of us who teach at NYU. No competition there whatsoever, Carla. And Carla's work has been focusing on leveraging real-world data and experience to inform the conduct of clinical and post-market drug safety and effectiveness studies. Carla has over 25 years in public health in local, national, international settings. She's done a lot with real-world big data for public health surveillance, including on viral hepatitis, HIV, influenza, SUD, liver, and kidney disease. So welcome, Carla and Susan.
So happy to be here. Thanks for having us, Jeff.
So one of the things that we talked about is using real-world information and evidence in terms of getting data on the people you're trying to serve. So can you talk to us about what the Reagan-Udall Foundation is? And also, you undertook a project, and I want to make sure I get this right, so bear with me as I look at my notes really carefully. The Real World Accelerator to improve the standard and collection and curation of race and ethnicity data in healthcare. So a very long title, but really important. So if you could just tell us, what is the Reagan-Udall Foundation? What is your mission? And how did you come about working on RAISE?
So I'll do the what is the foundation, and then I'm going to hand it to Carla for RAISE, as she is the principal investigator for that project. So the Reagan-Udall Foundation for the FDA, we're a nonprofit, non-government organization that Congress created. So there's only a few of those entities that exist, but Congress created the foundation to help FDA do more to protect and promote the public's health. And so we pursue projects that help the agency do a better job. In the case of the project that Carla is about to talk about, it's as the agent, as FDA and the industries that it regulates tries to do better at things like having clinical trials that are representative of the populations where the drugs or devices might be used, you need to have good information about who has the conditions that might be treated by those drugs or devices. And so that's a space where we can help the agency improve and help regulated industry improve what they bring to the agency. Other types of projects that we do is help the agency to understand or to be familiar with the real world use of the products that they regulate. So, right, what are some of the payment policies? What happens in the real world, things like we were just talking with them about nutrition policy and the fact that, in the real world, we don't eat things one at a time. We eat a plate of food. And so having kind of like figuring out, well, then how do I piece together the nutrition information so I understand all that's on my plate, not just one or a couple of things. So that's a food example, but it gets to that idea of what are the things that happen outside of the .gov and the regulatory activity that then can help FDA do a better job. So Carla, do you want to talk about RAISE?
Yeah. And as Susan said, there are things happening outside of FDA's direct purview that influence the work that they do and the things and the information they need to help make good regulatory decisions on medical product. And one of those things is really having a good understanding of population-based estimates of disease burden, of medication utilization. And one of the things that I've persistently noticed working with real-world data, both from a public health perspective, I've done over a decade in local public health and dealt with reportable disease data, of which race and ethnicity is a reportable data element. It's missing a lot, even in COVID-19. We know from the CDC that only 65% of reported cases of COVID-19, which was a reportable disease in a pandemic, had required race and ethnicity information. 65%. And it was a little bit better, 85% among those who have died. But that's a huge percentage of unknown. And when that's a missing data problem. And when you can't completely describe the population, then in the best case scenario, our estimates of effect of medical product or risk safety risk are underpowered, and at worst they're biased. And we know that this missing race information is not random. More people of color are reporting missing race. So how do we fix it? I mean, the root of this problem is really is driving the data that the FDA is able to receive, either through recruitment into clinical trials, because if we can't completely describe the population, then we can't know who's really at risk and do the appropriate recruitment to have an inclusive and representative trial of people with those conditions. And further, I think...
And I apologize for interrupting, Carla, but correct me if I'm wrong. Wasn't that a very big issue in terms of the vaccines and COVID, in the sense that the recruitment numbers, and I'm going off memory here, were generally somewhere in the neighborhood of, say, 10 to 15% for both Asians and African American minorities. But the number of people impacted by the disease for those two groups was upwards of 30 or 40%.
Right. I mean, you nailed it, Jeff. It's a huge healthcare disparity. And I think, risk this becoming worse if we cannot get more inclusive trials or meet people where they are.
And let me jump in on the vaccine question, because it relates to not only the information that we generate so that we can evaluate the products. It also relates to consumer acceptance. One of the projects the foundation did for FDA in COVID-19 was to just go out and talk to traditionally underserved communities to gather their thoughts and questions about a COVID-19 vaccine. And what we heard loud and clear is that these populations wanted to know that people who looked like them and people who lived like them were included in the clinical trials, right? Not overrepresented and not underrepresented, but are there people who live and look like me in those trials? Well, if we don't know what the people live and look like, then we can't have them in the trials. And then when I go to see, do I think this will work for me and for my family? My willingness to trust the data is decreased because I don't see myself reflected there.
Right.
And so Carla, what did you, as you undertook RAISE, and I think you've come to the conclusion portion of it, can you talk about, what you found and what were some of the barriers to collecting the data and what are ways to do that more effectively?
Sure, Jeff. And like, I think what I didn't talk about is what we did in RAISE. I mean, we
Oh,
knew
I'm
that
sorry.
there
Go
was
ahead.
this missing data problem, but we also know that there are really good solutions out there. But there's either a lack of really understanding of knowledge about these potential solutions and a bigger gap in being able to implement and operationalize and take to scale. So the missing data problem isn't just about people not reporting. I think that's a huge part of it. And part of it is what Susan alluded to, is that there's a lack of trust. There needs to be an improved trust in why, and part of that is with transparency. There needs to be an improved knowing about why the data are being collected, how it will be used, and how it will benefit the community or the patient themselves. Right? So there's that reporting. Then there's the collection aspect of it. Like, how are we asking the question? Are we asking it in ways that will solicit a response? Are we
what are we asking?
Are we asking?
First,
are we
asking?
Yeah.
Right.
Or are we observing, which perpetuates that trust issue again? And there's a lot of, I mean, especially as the US becomes more interracially mixed, people present differently than as they are, right? And then as you get towards collection, there's the whole curation aspect of it. How do we protect the data? How do we combine that data? How do we treat people that are reporting multiple races? How do we maintain that information over time as information gets updated? Because we know that race is not a stagnant variable. It's not a constant. It changes. People report differently over time. How do we preserve that, especially as we get to that last component of this continuum called exchange? There's exchange of data for healthcare purposes, for payer purposes, for research purposes. As data move from a single system, and even within a single system, multiple source data, right? Multiple vendors contributing to those data. How does it move? How does it get aggregated as it gets de-identified? How do we maintain that track of that patient? So we developed RAISE as a series of workshops to talk through each of those steps in the continuum, identify the gaps, but more importantly, the solutions that are existing, share them, and have a dialogue, a discussion about the pros and cons of implementing some of those solutions. And at the end, we came up with a summary list of learnings that is represented by an acronym called RISE UP, which you can see on our website. If you go to reagan-udall.org/program/research/RAISE, you can see what that is.
Just go to reagan-udall.org. You'll find it.
Yeah. And so can you give us a kind of summary of, like, if you had to pick a couple of the most important things you found in terms of getting the data and some of the solutions, what were the biggest barriers you saw? And then I want to come back to trust, but what were some of the biggest barriers you saw, and what were some of the ways to overcome some of those solutions?
Yeah, the biggest gap, and I think fundamental, I have to start with the trust. I mean, that's fundamental, and what we found echoed through each step, and that community is the solution, has to be part of the solution. There was a great quote from one of our workshops where it's not about research, community at the research table. It's research at the community table.
Yeah,
really
absolutely. That's a great
understanding. Yeah, what a community's core needs, wants are, and how they would define health equity, and moving forward in a way that supports that, not just our initiatives for what we think health equity is. And that opens up some of the other barriers, including one being a lack of transparency and understanding of why race is being asked. We know that race and ethnicity are a proxy for many different things, and we're being asked to define it according to the Office of Management and Budget guidelines. Statistical Policy 15, which has currently 5 categories of race and 1 separate variable for ethnicity, which happens to be Hispanic or non-Hispanic, which never resonated with me as a Filipino American. So
now don't that categorization goes back to almost the early 2000s, doesn't it? And is that going to be updated soon?
It goes before that, and there is a proposal for a change, and that proposal was driven, partly informed by community involvement. One of the proposals is to include now a category for Middle Eastern North African. One of the groups that came on to RAISE talked about how they worked with the largest Middle Eastern group in America. It's located outside of Detroit, called Access. And through that work, the issue is that people of Arab and Middle Eastern descent do not identify as white, and they do not identify as Black. So they really had no place to put themselves. And through the work that the group did for the All of Us project, the NIH All of Us project, they were able to advocate to include in a national survey this new category of race, which is now being considered as a permanent change to the OMB. But those data, those OMB categories were collected for purposes of tracking in government records, access to services for people that had been, previously privileged or discriminated against. But that's not how it's being used, right? People want to use race and ethnicity sometimes for biology, and race is a socio-political variable. It does. So we have to think about other variables that better capture genetic ancestry or that relate to geography, like countries of origin or something like that. But really
we didn't tackle
why.
that.
We didn't tackle
right. Well, because race and ethnicity is, you were right, in the current construct, it's used to help us understand and try and address those disparities, right? In that if you don't have the information to be able to look and see, it's hard to correct a problem that you haven't illustrated, and that you aren't then collecting the information to correct it.
So let me ask you a question, Susan. As we talked about, and Susan and I met for lunch, and that's how this it came about. When we met for lunch, talk about the practical aspects of this in terms of how this impacts both drug development, medical device development, even access to care, in the sense of it's a bit of an academic exercise to collect the data, because we can see how it impacts certain groups in terms of vaccines and other things. But in terms of companies and in terms of new regulations that, say, the FDA has, this data actually matters because it's going to translate into how this impacts the development of the different products. So can you talk to that?
Yeah, happy to. So, one of the things if you're bringing a drug or a device, trying to innovate and do the research to bring a drug or device to market, one of the hallmark ways you do that is to conduct clinical trials and see, does this product work the way that we think it will work? And it's important to understand and define the population that's in those clinical trials. As I mentioned, we know for consumer acceptance that people want to see themselves reflected in the clinical trial if they're supposed to be potentially using the product. And to know if they're there, you have to have the information about who was in your clinical trial and how do they live? What are things that are important about them? And so it's a bit of, there's this kind of the ecosystem of data is somewhat circular, right? In that, trying to say, if I want to bring a new treatment, let's just use COVID-19. Let's say that I wanted to bring a new treatment for severe COVID-19. Well, when I think about how I want to do my clinical trials, I need to know who most often experiences severe COVID-19. So I look in the health records and the insurance claims and gather the information. That the only information I'll be able to gather is, or uncover in those sources is what was gathered. So if it doesn't tell me if it doesn't tell me important things like race and ethnicity or even gender or some of that other information, then I'm somewhat blinded. So I only know what's in that information, and then I design my clinical trials based on that information that may or may not be complete. So maybe one of the ways to think about it is if you were painting a picture, you have to work from the color palette that is in the healthcare data that already exists in order to then set your color palette for your clinical trials.
Right.
You don't get to go beyond that because there isn't anything else there. So what's important here, we need to improve the quality and the quantity of the information that's collected so that we can draw a better picture of the disease we're trying to treat, to then better design the clinical trials and have better representation in the clinical trials, so that those who want to participate can participate. And RAISE didn't solve engaging in clinical trials. That's a whole other project that we that is right like underway. But I actually want to step back, Jeff, and do a bit about. I was thinking this morning that a common question when we talk about this is a bit of a, why do you need this? Why does it matter? How possibly does information collected in administering a vaccine, right, part of classic healthcare delivery, or administering a medication or getting a device, how does that play into this broader than developing new drugs or monitoring the performance of new drugs or devices? And so I want to step back and give you a whole new metaphor to think about the information.
Okay.
So let's step out of healthcare and think to something that is probably something that any of us have done, where you've gathered a group of people. When you're gathering a group of people, there's different information that you need depending on what it is that you're going to do, right? So if you're going to have at some time, if you're just gathering, you need to know a number of how many people are planning to be there. But you don't need to know much more. And in fact, if it's a virtual gathering, you don't even really need to know that. Need to, right? It could be as any. But if it's my table, I need to know if it's going to be 10 or 11 or 12 people.
Right.
I might also need to know if any of those 10 or 11 or 12 need something other than a regular chair at the table. Right? It becomes important. It's not important to me on a virtual, but it is important to me in a physical table if they're in a wheelchair or need some other, like some other different posture.
Mm-hmm.
If I'm going to serve food, I also really want to know their food allergies and their intolerances.
I see where you're going. It totally makes
sense.
sense.
And their aversions, right? Like different need different information.
Yeah, no, my sister's a vegetarian. You need a vegetarian plate. Some people don't like milk and cheese, or it doesn't agree with them, etc.
Right. And I didn't need that if I was just having a virtual meeting or if I'm having an in-person and I didn't serve any food. But so there's different information needs. What the challenges we see in collecting that information is that we have a history in healthcare of misusing that information.
Yeah.
Right? So what I have to create is an environment that says, if you tell me you need a different type of a seat at the table, I'm still going to invite you to the table. I'm not going to use that to exclude you from the table. Similarly, if you tell me that you have a dairy allergy, I'm not going to be like, well, shoot, I was planning on, right, a wine and cheese party and you just blew it up. I have to create an environment where I can ask for and collect that information and that I won't use it against you, but rather we'll use it to better serve you. That is something that we have to, that the healthcare delivery system and the payment system is trying to do a better job of every day. But it has to be intentional, and we have to do better at it. And then the way that Carla and I and regulated industry and FDA thinks about using that information is that it's not a situation where I can go out and ask again. We have to work from the information that's already been collected. So if it's not there, you're right, you're doing research about what has happened. The information has to be there up front. So it's not a metaphor where I can go out and say, okay, we're going to serve, I have to have already gotten that information. All of that then requires, to continue my metaphor, it's a bit of, we're going to be friends, and here's the information I need you to fill out to be in my cohort. Well, then we have to explain, similarly in the healthcare system, we have to better explain why we're collecting that information and how it would be used. And most importantly, that I'm going to use it to do a better job to serve you.
No, absolutely. No, I totally get that. So that brings me back to Carla's earlier point of trust and transparency. And, I was talking to folks at a hospital innovation area the other day, and we were talking about the ADKAR model for change. And, for those who don't know, it starts off with, awareness, desire, knowledge, ability, and I think reinforcement's the last one. But to get to the desire to have people to give you this data, they need to trust you. They need to know, they need to have that transparency. So to help people do that, what did you find that allowed people, Carla, to kind of feel vulnerable and want to say, in Susan's example, hey, you know what? I'm lactose intolerant. I don't want to get excluded from your wine and cheese party. And what are you going to do with this data when I give it to you? What kinds of things did you find helped allow organizations to collect race and ethnicity data and to give people that they were collecting it from the confidence that you would be used appropriately?
Yep. Yeah, I'd love to talk about that. But first, Susan, thank you. I mean, Susan knows her audience. She's speaking my love language of food. And so I think it is a great metaphor to think about, how we can serve people better. And we do know that patients over and over have reported a willingness to provide information, a willingness to engage in clinical trials, a willingness to do these studies, but they need to know why. A lot of the reasons why they do not participate is because they don't know exactly why, the what, and the how does this benefit you. So we do really need to make that transparent. So one of the things that the problems that we identified in RAISE was the simultaneous problem of having too much and too little information regarding the choice of the racial categories. And that, again, our solution to that is really to start locally, is to focus on local information and being able to engage the community. So healthcare organizations are really grappling with right-sizing the number of race and ethnicity options and standardizing those options. So what we saw was that there are large electronic health record vendors, for example, that do work with their clients in certain geographic populations and are able to create a product that is more tailored to that population. So one of our solutions was to establish a clear goal of wanting to improve the collection of those data to inform existing standards and protocols, doing some research to develop a menu of race and ethnicity responses for a given healthcare organization's catchment population that would involve the community and having their input.
And can you just help me out with, and I don't mean to interrupt again, but help me out with, what were the kind of basic mechanics? How did you help? What did people say? what ways did they suggest going out into the community? What kinds of things did you find worked to do that research?
Right, working through one research group worked with a trusted community organization where there was a lot of involvement. I mentioned about that Northeast, the Arab Community Population Center. It's called Access
Right.
in the Detroit area, and really having them explain their needs and creating a tool that creating categories, identifying the categories that were meaningful to them that allow them to self-identify. And with that, then once the community is able to identify how they best self-identify, you can there are already existing value sets, like the CDC's value set for race and ethnicity includes 900 plus options for race and ethnicity. But no one wants to go through 900 options when you're trying to get a mammogram. Right? You need to be presented with those that are relevant to your population and to your community. And we see this across the board. We know that EPIC, for example, has different population categories for their in care systems that are in the West Coast versus the East Coast versus the South, based on what the population is. I, for a long time, was an investigator at Kaiser. And I know that the racial categories in the Mid-Atlantic for Kaiser are different than those in Northern California. So, and
then that comes to some of the curation, right? Because you need that localization for collection, but then you need a way to crosswalk and say, how does that, translate to those OMB buckets that are what have to be required, that's what's required in federal regulatory submissions. So that's some of the curation piece. And that's another one where I'd say we exposed a challenge that I don't know that we've solved, but some of the ways where sometimes you'll see conflicting race and ethnicity information, right? And that can change based on how much do I trust you who asked me information for my mammogram versus how much do I trust you who asked me information for my vaccine shot. I might give different answers. I'm actually quite right. And so what sometimes happens there, if there's conflicting information or it's more than one race, is that it either gets dropped out,
right,
not so helpful, or it gets thrown into a multi-race, which actually just it's about the same as dropping it out.
Yeah.
Because, right. No. If you go back to my allergy example, if you say lots of allergies, can't help you. that doesn't help me refine my menu. Right.
Yeah. So multi-race. Yeah.
Go ahead, Carla.
I was just gonna say, and multi-race isn't one of the OMB categories.
Correct. That's one of those things that happens in a curation, right? Of trying to say we don't want to lose the information, and yet in the same way you still lose the information. So we have to get better at how we both that collection and then the curation and use.
But in terms of one of those standards, Jeff, sorry, I just want to close that out. Like one of those potential solutions was this, it's both starting locally and getting the information you need to pick from these standardized options out there, the 900 plus from the CDC value set that do roll up to the 5 OMB categories currently. And we just need to be able to have an opportunity to look at the granular level and see best how can we, what applies and be able to standardize that. And going to those value sets that are standardized, that do roll up to the federally reported categories that we all need if we're going to submit to federal regulators or get federal dollars. We need to have that. And it's just a way of life. And maybe in the future that will change, but that's our reality.
Let me ask you this question. One of the things we did a blog on this a couple months ago about hospitals and providers collecting social determinants of health data. And one of the pieces we read came back with said, initially the people in the clinic were like, the doctors felt it took too long. It was too burdensome. The other clinicians felt it was similar. And by the time after everybody collected it, they found it actually wasn't so bad. So did you come out against that? Did you come up against that argument? and what types of things, if someone says, yeah, well, we don't want to collect this, it's a pain, it's more, we're already overworked, we're spending 90 minutes a night in pajama time, I don't have to enter in another field to the EMR. Did you come up against this, and what did you find you did that was effective?
So true. I want to highlight the burden on providers, frontline clinicians is huge. And so we learned through RAISE, actually our first meeting, our kickoff meeting, we had Oscar Benavides of Massachusetts General Hospital present on work that their group did in the pediatric department to really understand and sit through the process of intake at registration. Their goal also to improve collection and reporting of race and ethnicity, and see how their teams were taking in the information, and the interesting finding that they had was that even though that frontline receptionist staff see taking it out of the provider's visit, right? So not another thing for the doctor to do. Can it be something outside of that room in the registration? But when they interviewed the registration team, most people thought, there's a high level of importance of health equity, but they didn't see the connection between collecting race and ethnicity information and health equity. So there needs to be a better communication about why these data are important, how it can inform health equity, and do the training. How do I sensitively ask about why is it important to ask? Why can't I just observe it? And do that, and be able to do sensitive, culturally humble training about how you can ask these kinds of questions sensitively and in a culturally, sensitive way. And really
humility,
understanding their workflow, so that
humility, right? Humility might have been an underscoring component of all the solutions.
Yeah.
Right. In that this is not I can come in and solve it with one thing or two things. It's how do we better understand why we're collecting in the information, how the information we're going to use it, and who should be involved in asking.
Right.
All important.
Well, one last question I know I wanted to get to, and I thank you for your time. I didn't know if there are any questions, David or Abby or Catherine, but one question I did want to ask Susan is what you had talked about, the kind of payer myth that payers would say, we're not going to collect this. I'm not sure, you could phrase it better than I can, but could you just talk about, what is that myth, and how would you overcome it?
Yeah. So one of the things that I've heard, in where we've talked about our project is they've said, oh, well, payers don't collect it. They're prohibited from collecting it. It's illegal for them to collect it. They're absolutely not going to collect it. Just not consistent and not true. And so there are what is illegal is misusing the information. And so the collection and then applying, again, it's back to this trust piece. And Carla, you have some of the specifics on this, but it's important for the payer to understand the population that they're covering. And so this is helpful information, and then to use it again in a way to better serve that population. So I think there's the myth of payers can't do this. That's a myth. They actually can, and many are, and more should.
And the value-based payment models, these alternative payment models that are being pushed by CMS, all require having race and ethnicity data, and as a way of improving metrics on access to mammograms, or like those health equity, those measures of quality and care. And
yeah, I was going to say that isn't this an emphasis of the Biden administration and of the REACH data of increasing the collection of race and ethnicity data and doing it in an effective way.
Right, and effective and a way that helps us all, that we have a better understanding of the interventions and the outcomes of our healthcare system.
So that we know that mammogram screenings aren't just up from last year in women, all across women of reproductive age, but in all women of reproductive age across all racial categories. You can't know that if you don't have the race and ethnicity information. We can't address maternal mortality properly if we don't have race and ethnicity information. I mean, we already know it's a huge disparity. Is that just the tip of the iceberg? And how are we not, identifying these things earlier or being able to help the population? And the new, these new payment models really emphasize being able to construct systems to collect this information. There's money out there to be had to retrofit information systems to be able to collect and capture this information, and as it aligns with improving care and access.
Right. Well, Carla and Susan, I really want to thank you. This has been incredibly informative. I highly suggest people go to the RAISE report. It is on, the Reagan-Udall site. This will increasingly become an issue, and helping people understand and feel comfortable why you're collecting the data and how you're going to use the data and how you're going to protect the data, I think is really super important. And we thank you very much both for your time and wish you a wonderful, happy holiday season and really appreciate it.
Absolutely. Thanks, Jeff.
Thank you,
Jeff.
Thanks, Carla. So with that, as you'll notice, we are down to just me as a host today. So we're going to go right to our quick hits, and I will try to do this all in one piece. First article, which was incredibly interesting from Bloomberg, was that Amazon had once inspired fear in healthcare, but no longer. The crux of the article is that Amazon has spent a decade working on healthcare, trying to reinvent healthcare, but their inability to make decisions and incorporate the healthcare expertise that they brought in has left them with a very traditional approach using very traditional mechanisms. In essence, the argument for the article is nothing they have done has been incredibly exceptional or had exceptional impact, which I think is still a little early, but I would agree with that. One of the conclusions of the article is that all of the things they've done have been modified or scaled back. Importantly, I think Amazon, the article points out, has let technology managers with little or no healthcare expertise take over some of these projects. And I think that's been a big mistake. They generally ignore a lot of the experts they brought in, according to the article. And because of that, they haven't had as big an impact. For example, only about 6% of the pharmacy business in the US is Amazon Pharmacy, which is really a drop in the bucket. Similarly, they've only got about 800,000 members with One Medical. That's barely a small percentage. And interestingly, One Medical has now been taken in. You can get a discounted membership through Prime. I don't know if you remember when Prime started taking off and you could get the cheaper Prime membership, but the numbers were huge. Only about 16% rise in One Medical membership since it became part of Prime, so not a big impact. I think the lesson here is that you have to incorporate people from healthcare from the beginning. You have to incorporate multiple points of view of healthcare, and you have to build it from the ground up. So interesting to see how this all turns. As Carla referred to, the healthcare disparities in care are huge. There was an article about preterm birth and infant mortality measures in the U.S. remain stubbornly high. Approximately 10.5% of the babies born in the U.S. are born premature. That's defined as before 37 weeks of gestation. This is really a national crime, frankly. Our national average is about 10%. It's much higher than other industrialized countries such as the UK, Italy, and Japan, which are between 5 and 8%. In addition, this data adds to the picture of disparities that Carla was referring to in terms of childbirth outcomes in the US. About 15% of babies born to Black families in the U.S. are born premature, and that's versus 9% for white and Asian. The infant mortality rate for Black babies in the U.S. is 2.5 times what it is for white babies in the U.S. As I said, this is a national crime that we can and must do something to address. There are a number of ways in terms of virtual care and digital solutions that can help in terms of prenatal screening, prenatal care, and other things. And we really have to do something about this. Next was an article from the Commonwealth Fund about private equity's role in healthcare. The article was written by David Blumenthal, former national coordinator for Health IT. He has been an opponent of Medicare Advantage. He's arguing that there's been a change in the way that PE and firms are investing, and they're essentially corrupting healthcare more or less. What he's arguing is that the PE firms are leveraging their healthcare investments to take out loans against the healthcare assets, pay the investors and the PE firms back, and then salvage these or saddle rather the healthcare companies with debt. In addition, what David is saying is that they are buying facilities, trimming fat. A number of people argued that they're trimming fat to the bone, and then essentially unloading these hobbled companies on strategic investors. I would say I only partially agree. I think, first of all, when rates were extremely low, the strategy made a lot more financial sense. You could borrow much easily, and you could carry much more debt. Now that rates are up dramatically, the servicing of debt cost is much harder now. In addition, some trimming to the bone, some trimming makes sense, but the strategy only works if there's waste in healthcare. And we know from a number of examples and a number of studies, there's tremendous waste in healthcare. So there is probably room for a strategy like this. Net, I would say there's a ton of places to point fingers. I don't think PE is the only one. But like Amazon, I think some of these PE investors have become confused that their intelligence with luck, given how frothy the markets were and how low rates were, I think this is going to be much harder going forward. In addition, there was an article we had talked about last week that Cigna had put up its MA business for sale. An article in the Wall Street Journal that Cigna and Humana are in talks for merger. This is incredibly important because if Cigna were to merge with Humana, they would have to divest their MA business. This would have to occur first for this to have any chance of approval. Excuse me. I do think that a deal like this would face incredible regulatory scrutiny in front of the FTC. This would take a long time. I see this as being a very tough deal to get through. In the near term, this would benefit some of the other players, but I really think that this is probably an unlikely combination, but more to come. And then finally, former Google CEO Eric Schmidt said that companies' AI guardrails aren't enough to prevent harm. Eric Schmidt, speaking at the Axios AI Summit in DC, argued that companies putting up guardrails to prevent harm themselves aren't enough. He had penned an article in Financial Times and excerpted here, basically saying that you need an intergovernmental body to form with industry experts to do this, and not the companies themselves to prevent harm. He thinks that would help prevent political interference, and I think that's a nice idea. I think it's very unlikely. I think governments are going to continue to want to be involved. They're going to continue to want to prevent harm. As you can see with what went on with OpenAI and some of their new developments, I think it's just going to continue to result in interference, frankly, and overregulation of AI in the near term by governments. So we encourage you to check out all those articles. With that, I will thank you very much for joining us. This week's blog, given everything that happened with OpenAI, I want to call your attention to a prior blog post called Navigating the Ethical Landmines of AI in Healthcare. You can scan the QR code and check it there. Please do connect with us at Healthcare Strategy Bullpen. You can reach out to me on LinkedIn. You can follow us on LinkedIn as well. You can also follow us on Twitter at healthcarepen.com or X, whatever they call it now. We'd like you to think of us as the Rosetta Stone between technology and healthcare that's helping bridge the culture and language of healthcare and technology and help you adapt and deploy your healthcare tech to improve the lives of patients. So please do connect with us. I'd also like you to encourage you to subscribe to Diagnosing Health Tech by scanning the QR code in the screen, getting weekly invites to the show. As we mentioned earlier, it is on your favorite podcast app. So search your favorite podcast app for Diagnosing Health Tech. Also like to remind you the show is brought to you and sponsored by Redox as well. Redox is the healthcare integration platform that specializes in the implementation of big data, AI, and cloud computing. I want to thank you all for joining us. Please do join us next week when we will have Namrata Rastogi, who is experienced with the National Health Service on, looking at populations and helping get to populations and understand what you need to work with underserved and better served populations that you're trying to work with. From all of us at Diagnosing Health Tech, thanks for watching, and we will see you next week. Thanks very much.